Good morning, everybody. Welcome to Dr. Tom's Tips on Tuesday's Case of the Week. How is everybody? Hope everyone's doing well. Today, we got a really cool procedure with Dr. Tom. Dr. Tom, how are you?
Hey, good Rolando. Hi, everybody. Groovy Tuesday. So let's go have some fun.
So
Today,
what's the case?
Today what we're gonna talk about is we're gonna talk about an extraction and a graft and instant anesthesia and how Isolite kind of helps you in all these procedures. So let's rock and roll.
Oh, cool. Wow.
There we go. So I was on a hike, and that picture a couple of weeks ago, and that picture was just so gorgeous. I just thought it'd be a good way to start. It was a beautiful sunset with a great tree. I was up on a little trail just above my house. It was gorgeous. Here we go. Tooth number 19, extracting and grafting tooth number 19. Big defect on the distal aspect, referred to the endodontist. They said it was not possible to save it, probably a fracture, so we decided to take it out. I've talked about this part before with the Stabident injection, just how to get instant anesthesia. You see me just poking right through the alveolus there, through the attached tissue. And then after that, I'm pumping that up and down just to make it easier to find my needle access point. And I put the anesthesia in there right now. And literally, within just moments of me going ahead and injecting the anesthetic in there, I mean, I can, as soon as I take the needle out, I start. And the patient is numb immediately. So practice management. Maximize your time. It's really critical to maximize your time. Okay, so he had a crown on the tooth, and we had to cut the crown off. Goes pretty quickly. I know people spend hours and hours taking out crowns, but just get right to it. If you've got a zirconia crown, you're going to be there all day, unfortunately. But this is just a PFM. Just a great little tool, like a little screwdriver, if you will. Just bang, give it a little twist, and man, look at it, just comes right off. So some people would have gone in here with some cow horns. I decided, since we're going to extract and graft it on this particular one with big fat roots, might be easier to separate this too. So I just kind of separated it right on down from the top. And the thing that's kind of cool about this is you see the Isolite keeps that tongue out of the way. You know, I don't worry about the tongue, and I don't have to have my assistant retracting the tongue, and I don't have to use the hand retracting the tongue. And if I'm making a surgical incision, the tongue is out of the way, and I just concentrate. You know, I've got this nice, open, well-lit, wide open operating field that I can work in without the tongue getting in the way at all. And you don't see my assistant's not in there suctioning either. So this part's real easy. Just took a little scalpel. We have our luxators, so we did a little. Once we got root separation, we took a luxator in there, separated the roots, grabbed a forceps, and just took them out one at a time. Divide and conquer is always a lot easier. You know, that way you don't have to break root tips. There's nothing that I hate worse than digging for root tips. These were, even separating these were tough to get out. And I was trying to conserve as much bone as I possibly could. Didn't want to remove any extra bone. Distal root first, mesial root second. But you can see, just God, sometimes these things are just tough to remove. And I think if you notice throughout this whole procedure, my assistant was not in there once evacuating anything. So just my Isolite is just doing such a great job sucking everything up. You can see the blood being sucked up in there. Make sure that you flush your Isolite out immediately afterwards so that you don't get any coagulant built up inside the tubes there. The little sucker was hard to get out.
Yeah, that you're working that one.
Yeah, it's just hard to get out. So there we go. Yeah, more elevation, more elevation. Finally, it works its way loose. But it had some big bulbous root tips on that thing.
Oh, here we go.
Yeah, we eventually get the mesial root out.
And
yeah, finally. Boom. Okay, curate out the socket. Go back in there, and then I just wanted to debride the socket down inside there. So I took a number 8 round burr, went down inside, cleaned out all the granulation tissue that was in there. And then, you know what, I decided I wanted to graft. We're preparing this for an implant. And so we're going to do a little graft, and I wanted to put a membrane over this thing. So I had to go back in and make an incision so that I could reflect the tissue a little bit more. It's just one way to do it. Might have been easier to reflect the tissue initially speaking, but at the end of the day, it was all the same. So periosteal elevator. Yeah.
And your patient doesn't seem uncomfortable.
No, not at all. I mean, just once again, the nice thing about this. Oh yeah, sat down there. He was on some blood thinners, and so he was really bleeding a lot. So we had a little bit more blood than we usually have in this procedure. So we had to soak that up with a little cotton roll there. Take my little pluggers, plug that down in there. No magic other than just routine dentistry. It's just kind of the interesting point of this whole thing was that most of the time there's just no additional suctioning going in except for my assistant right there. It's just six-handed dentistry with just the two of us. And in a moment here, we're going to throw a little membrane in there. Tuck it in. Buccal and lingual, tuck it in. Throw a couple of sutures in, and that's pretty much it. But it's just real easy. Everyday dentistry, nothing fancy about this at all. Just get in there and get the job done. The points of this case that I think are kind of nice is A, the instant anesthesia, where we're able just to start right away, and B, the fact that, I don't fight the tongue, don't fight saliva, got lots of room to work. So point being, even with oral surgery, I think last week it was some kids, we took out a couple of teeth, but even with the more complex oral surgery cases such as this, there's our end result. You can utilize the Isolite.
Awesome. That is fantastic. Thank you so much.
Yeah.
It's amazing to see that during the course of the procedure, no muss, no fuss, and it's pretty straightforward. Quick question. We've had viewers asking, especially with regard to the extractions, they've had difficulty extracting like second molars, third molars. Do you have any tips or tricks with regard to that? Also, with regard to Isolite.
Yeah, I do. So, Isolite doesn't work in every single situation, every single time. Hey, and if it's in your way, take the doggone thing out and set it off to the side. Don't try and fight the mouth and the patient and the Isolite at the same time. Too much work. But I do have a tip for anybody that's doing third molar extractions. The way the Isolite is shaped for third molar extractions, this rests on the retromolar pad right down here. This goes up in the hamular notch, and those are areas that you have to access to get to your surgical site. So even though Isolite doesn't make the recommendation to do this, I, as a clinician, make the decision of when I can trim this and when I can't trim it. So it's entirely up to me. So if I'm doing a third molar extraction and the whale's tail part is in my way, it's real easy for me to make an adjustment. I just pick up a pair of scissors like this. I cut it off. So now I've lost that part. This portion right here, the tongue retractor, still keeps the tongue out of the way. It still protects the airway, but now it gives you access to the whole surgical site. So if you're doing mandibular third molar extractions or even maxillary third molar extractions, you don't have this part coming around and wrapping out on the cheek. Once again, not recommended by Isolite, but clinically I do what I got to do to get to the situation and still keep my patients safe. That answer that question?
That is awesome. Thank you so much.
Yeah.
And with regard to blood, you mentioned the context around blood and water. What was that?
Oh yeah. Your patient's bleeding. This is aspirating all the blood. It's aspirating all the saliva. What your assistant can do is she can put a little water down on the floor of the mouth. It'll suck it all up. That will clean the lines. But the other thing that's important is when immediately after you take this out of the mouth and you're throwing everything away, go ahead and flush your Isolite head and system with lots and lots of water. Get a bucket of water, put it in the sink, just flush it with lots of water so that you don't clog up the inside of so the blood doesn't accumulate on the inside of the tubing in there.
That is fantastic. Dr. Tom Hirsch, first of all, I am fascinated by the cases that you show us. I really appreciate it. Those of you who are watching this, if you like the content, please share it. If you have questions for us, if there are things that you'd like to see, please send them over to us. Dr. Hirsch will be back
Yep.
on Tuesday next week at 10 for Dr. Tom's Case of the Week at 10.
Okay. Thanks, everybody. Have a great one.
Thank you, sir. Appreciate it. That is awesome.
Get your shots.
Take care.
Okay.